So now we're going to move on to Vivien Tsu, who's going to present on scaling up comprehensive prevention approaches for cervical cancer control. Vivien is an Associate Director of PATH's Reproductive Health Global Program, a Senior Advisor on cervical cancer, and she's Director of the HPV Vaccines Project at PATH. She's also an affiliate professor of epidemiology at the University of Washington. In her past 30 years at PATH, she's carried out a variety of studies evaluating new technologies and innovative approaches to public health problems related to the health of women and children. She has worked on cervical cancer prevention for more than 20 years and is currently responsible for PATH's breast and cervical cancer programs. Thank you, Vivien.
Good morning, everyone. I'd also like to thank the organizers of the workshop because they've given us all a chance to really reflect on how far we've come in both vaccination and screening and to think about where we need to go next. As we've heard from the previous speakers, we now have really unprecedented opportunities. We have new technologies that we've heard about this morning. We have validated approaches like screen and treat and reaching young adolescents with vaccines. We know that the price of vaccines has been coming down, and now with Gavi funding around for Gavi-eligible countries, that's a new opportunity. And we also have this opportunity of the environment, the momentum that has been building around non-communicable diseases. Screening and vaccine have both been labeled by WHO as best buys in the whole NCD arena. And we now know that cervical cancer indicators are going to be included in our way of looking at NCDs. Why not then just have each of us continue as we've been doing to pursue our own special areas of interest and expertise, whether it's vaccine or screening? I think it's actually very important that we all recognize the value of a comprehensive prevention approach and actively support it. We know there are some real synergies in raising awareness about cervical cancer prevention because raise awareness about both screening and vaccine both help create demand. So if we talk to communities about vaccine, they say, what about our older women? Is there something we can do for them? If we talk to women about screening, they say, well, we hear there's some vaccine. Can we do something to protect our daughters? So there's some real synergy in talking about both of them together. It also engages a much broader range of stakeholders. We get people from not only the vaccine community, but we get people from the cancer community and from adolescent health and from reproductive health to all come together and support it if we approach it in a comprehensive way. We know also that vaccines take a long time, as Scott mentioned, to see an impact. If we have screening going on at the same time, we can see that impact earlier, and it can help sustain support for both programs by having people see that there's a real result that they will benefit from it. There's also a really important issue of generational equity. There's a lot of excitement about the vaccine, and in some ways it seems easier to implement vaccination. It's something we know how to do. But there is important not to leave behind the women who are already potentially infected and already affected by the virus and who won't be able to benefit from the vaccine. Also, the vaccine's not effective against all oncogenic HPV types. So we will still need screening programs to be in place to capture other types that may be causing cervical cancer. And there's also a benefit in the reverse direction. In the long run, the vaccine will actually ease the burden on screening programs, as there will be fewer positives that will actually need follow-up and treatment. So there are mutual benefits in many ways for taking this comprehensive approach. It also allows countries to start from where they are. We heard already, some countries have piloted a vaccine. They can start building from there. Others have already started with VIA or with HPV. And by talking about it in a comprehensive way, there's a way for people to start and build from where they have begun already. So there are some essential steps to think about for scaling up, and that's what I want to share with you in the next few minutes. There are at least 6 essential steps, and I'll walk through them with you. As we heard from Dr. Murillo and Dr. Geronimo earlier, there are now many options for screening and for treatment. And policymakers have to consider what will work best in their own national context. especially what is scalable and available with existing human and financial resources. So these are some of the issues to consider, policy issues around screening and treatment. Which tests do we want to use? In which setting? Because there may be different tests even in different parts of the same country. Which treatment? Which level of service do you want to provide the services at? And which kind of providers are be authorized to do different kinds of tests and treatment? In some countries, only doctors can do cryotherapy. Many parts of Latin America. In other places in Africa and elsewhere, nurses and others have been trained to do cryotherapy. Which algorithm? We heard several choices of algorithms this morning. Whether we're talking about screen and treat without any triage or diagnosis, or any of these other combinations that may occur. What age range of women should be screened, and with what frequency? These are all decisions that need to be taken that will shape a program. Whether we're using a single visit approach or a referral for treatment through the kind of cluster or hub and spoke arrangement that Jose talked about. There are also policy issues on the vaccine that need to be considered as national programs are developed. When do we introduce the vaccine? Do we start right away? Is that something that's a little further down the road for us? Which vaccine do we use? We have currently 2 vaccines, a quadrivalent and a bivalent. Which target group? Are we going to go by age or by grade? And are we going to do 1 year at a time, or are we going to do a catch-up, as some countries have done? Which dosing schedule do we use? There's standard dosing schedule, but there's now information about alternatives, and several countries have decided to use alternative dosing schedules where they have the first 2 doses and then postpone the 3rd dose till 5 years out in the program, and data are being collected on that. And which delivery strategy? We heard some description of several of the different strategies that are available, and whether you integrate this as a single program of vaccine or whether you do it as part of a more broad community program. So there are many choices here to be made. Once these critical policy decisions have been made, it's time to translate those decisions into a national strategy, and that strategy needs to be time-bound and practical. We're talking about usually developing a strategy that is over a 5-year period, but it could be a 10-year strategy. Most of these things will take time to build up, and they really need to be phased in. Many countries think first off, oh, we're going to screen everybody the first year. Probably not so practical. And when you start thinking about the data that you need, the actual numbers of eligible populations, it becomes more realistic to think in terms of phasing in. We really encourage countries when they're developing these national strategies to pull all the numbers together first. It's very sobering sometimes when countries have grand plans to actually sit down and calculate the numbers of eligible population and realize, we heard Jose say, we've got 1 billion women to screen around the world. When countries sit and realize that perhaps they have 1 million eligible women in their country, they will begin to make a 5-year plan or even a 10-year plan. But that's more practical and more likely to actually occur. They have to make an inventory of what's available already and then prepare to meet the gaps in the equipment needs, and also to prepare the key messages and figure out what channels are the best way to reach communities with those messages. There are 2 different approaches that are often talked about for phasing, and I just wanted to focus on them for a moment. A traditional approach often taken for introducing new clinical services is to cascade them down from the national level to the provincial level, and then from there down to district and primary healthcare facilities. And this has some advantages because it spreads across the country right from the start, and you get trainers trained. But it can take a long time to trickle down, especially to the more remote communities. And in the case of cervical cancer, where you actually need screened patients to practice treatment on, it can take a time to actually generate enough of those patients who are screen positive to give providers time, patients for practice. So one approach that we would suggest that be considered is what we call the multi-level wedge, where you actually take a section of the country and do all 3 levels as a starting point, starting with making sure you have your tertiary care in place, that you have the referral care in place, and start screening right away so that that feeds screen-positive patients up into the secondary level for training of treatment, and move them up also to ensure that your specialists at the tertiary level are able to reinforce their skills. That's a risky strategy sometimes because it means starting in one geographic area first, and that can sometimes be politically difficult. But it does have some advantages and is worth considering. Here are just some examples. In recent years, several countries have gone through this process of developing national strategies and guidelines. Only a few of these have actually incorporated vaccination in their plan, but several are now in the process of developing them. With the Gavi-funded demonstration projects providing support now for comprehensive cervical cancer planning, I expect we'll see many more of these plans coming on in the next few years. As we all know, writing a plan doesn't automatically lead to successful implementation. We also have to build both political support and community support for it. And to build political support, we need to map our key stakeholders and understand who are the supporters, who are the likely resistors. We heard from Raul that there are sometimes resistors within the health system. And who are the uninformed, who just don't know. We want to especially focus on health officials, politicians, professional societies, and external partners, because they can all have a big impact on what happens. If we then assemble our evidence on disease burden, local evidence where it's available, and the estimated or modeled impact that we can have from the program that's going to be developed, and we often need to have cost-effectiveness data and look not only at cost-effectiveness but affordability of the selected interventions. And these are the elements that will be critical for political support. Community support is a little bit different, but if we want the new services to be accepted and taken up by the community, then we have to be attentive to the key elements of community support. First, we want to assess the level of awareness around issues like cervical cancer. Many communities don't know the name cervical cancer, but when you describe the symptoms, they recognize it as a disease that's present in their community. We also need to look at potential cultural concerns around screening, treatment, and vaccines, and the factors that are likely to foster community acceptance and support. Some of the factors that would have been identified in the experiences that we heard described today, the demonstration projects and pilots. We then want to identify the key influencers of women for health decisions, and we know that includes family members, their partners in particular, and often influential people in the community are important to them. And we have to align our communication strategies with those concerns that we identify and the factors that we know will influence them. A critical point without which none of this will happen are the financial resources. So even when there's good political support for a national strategy, it doesn't automatically translate into financial support on the budget. An essential part of the planning process is to determine the budget needs for both startup costs and for those recurrent costs that will continue. And we have a wonderful new tool in hand, the WHO costing tool, that is available both for screening and for vaccination to help a country sit down and figure out what budget will be needed. Once you know the budget that's needed, you can look at the financial sources that might be available, which could include either national and or even district budgets where decentralization is an important feature. In some countries, health insurance is becoming more common, and we need to look at that. And then cost recovery through fees may be a partial source for the program. External donors can be important. For example, Gavi for the vaccine, if the country is eligible. And co-financing from integrated approaches, where there are already programs in place for deworming or vitamin A, where that could be wrapped together with vaccine, for example. And again, it's really critical to adjust your plan if you haven't got the budget sources. So you can make a wonderful plan, but if it doesn't align with the resources you have, then it's not going to go forward. Once all these elements are in place, preparations actually begin. Many of those steps go on simultaneously and are done by different sections within the ministry. Strong leadership and coordination are essential. So we know that training is important. developing communication materials for these various audiences, ordering the equipment and the supplies and being attentive to needs for repair and maintenance and reordering, adjusting the health information system to get those elements incorporated into the new system, and doing microplanning, as Scott described, for vaccine is also important for screening. So finally, we have implementation. We begin with community education well in advance, as Scott noted, do intensive monitoring, and when problems are identified, it's critical that we respond promptly to those. Oops, sorry. And then we need to use data that are generated by the health information system to assess performance against the targets that have been set and provide feedback. So we know now that there are lots of options available for affordable screening and HPV vaccine, and there are many synergies for combining them in a comprehensive approach, although the timetables for those may proceed at different paces. We need to select strategies that will allow for the greatest coverage, including in low resource areas. So we really want to deal with equity issues to make sure that remote rural areas are not left out of the program, and build monitoring and quality improvement in from the very start. We need to think long-term and recognize that the program will change over time. Thanks very much.